So today we'll start on time. It's 5 o'clock. I know a few people are still joining. It was a short notice, but we're very fortunate to have this presentation that's not just timely, but it's much needed. So the presentation is Surviving the Tripledemic in 2025, COVID, Influenza, and RSV. And we have Dr. Joanna Schaenman. But before we get into the slide deck or her presentation, just a bit of a background or some important slides. The disclaimer is that this information that we are providing is for information only. So please don't act on anything till you speak to your healthcare provider. And just a couple of things, I was going to spend a bit more time, but I want to give Dr. Joanna Schaenman the stage because she does have, and we want to give, and please do ask questions. You can put in the chat box. You can also email us, but chat box is preferred. But I do want to bring up our Rose Parade. We had a float in the Rose Parade this year. And it, as you probably know, it won the very prestigious Isabella Coleman Award. And we're going to have another float in 2025. And just the title of the float is called "It Takes Two." It's a take on the Rob Bass song from the 80s. It Takes Two. There's a remix that's going to be playing, and it takes two, meaning it takes a simple blood and urine test to diagnose kidney disease. It's a kidney donor and a kidney recipient. And as you can see over here, there are two kidney-shaped trees, and there's a doctor and a patient. There's also a lotus. And the lotus has special meaning. It's a beautiful flower that grows in murky, muddy water. So this represents our patients who overcome adversities. And then the hands that it's in your hands. There's a hummingbird. So there's a lot of symbolism in this float that I will be going over in a bit more detail in one of the future presentations. We have, if you want to participate, there's dry volunteering. There's also floral that starts on December 26th. And these are all the different events. Christina will be sending them out to you. I do want to point out Buy a Rose campaign. This was very popular last year. You can text at 41444 and just say buy a rose, no spaces in between. It's $10 starting for one. And you can buy a rose for anybody. It doesn't have to be linked to kidney disease. It could be your loved one, your admired one, somebody that has played a significant role in your life. So please do buy a rose, and there's going to be a digital wall called the tribute wall that the name of the donor and the person that you are buying that rose for is going to show up. And this is our contact information. You probably all have that, but if not, please let us know. And with that, our today's special, Dr. Joanna Schaenman is not new to this group. She's actually one of the most popular presenters we have had. And she's an ID specialist, but a specialist in the transplant field as well, which is very relevant. So she'll be speaking about patients on transplant, dialysis, kidney disease, but anybody in general. And the topic is surviving the tripledemic in 2025, COVID, influenza, and RSV. So with that, Dr. Schaenman, you can start sharing your slide. And thank you very much to be here on such a short notice.
All right, super. Thank you, Dr. Rastogi. Thank you for giving me the opportunity to talk about a topic near and dear to my heart, which is vaccination. Okay, I'm sharing my screen and let me start my slideshow. Here we go. Yeah, so as was mentioned, I'm happy to take any questions. Please put them in the chat as you think about them. Wanted to talk about surviving the tripledemic in 2025 with a focus on COVID, influenza, and RSV. Those are really the big three of respiratory viruses. This is some of my disclosures, none of which are relevant to this presentation. And these are some goals for today: to talk about clinical impact of flu and vaccination options, to understand impact of COVID-19, RSV infection and new vaccines, talk about recommended vaccinations, and come up with a plan to keep you safe. Now, if you've seen this talk before, I am using some of the same slides, but I have updated any key points that required updating. So there will be some new information as well as updated information that's relevant for 2024. So I always like to start with thinking about the history of vaccines. I think for some of us, the first vaccine that we encountered was COVID-19 vaccine, but the history is much older, starting with Jenner, who came up with the idea that you could use live virus from cowpox to protect against smallpox. Pasteur came up with the rabies vaccine. This was followed by the idea of using a live attenuated virus for polio, and that's how measles, mumps, and rubella vaccine was created. The more modern era of vaccines really starts with these subunit vaccines when we developed recombinant DNA technology, and that describes the flu shot, hepatitis B, and pneumococcus. But we're now in the most recent era of vaccinology where we have now RNA vaccines, and those were initially started with SARS-CoV-2. But as you will see, we have an RNA vaccine for RSV now. So the history of vaccines is long and has really helped protect mankind from preventable illnesses over the past few hundreds of years. So to put the respiratory viruses in context, I wanted to share this slide that I actually use when I'm training the nurses and transplant coordinators, just to remind you that there are other vaccines out there, including MMR, Tdap for tetanus and pertussis, Shingrix to prevent varicella, especially if you're over 50 years old, the Prevnar 20 or 21, Heplisave for hepatitis B, the HPV, that's human papillomavirus, especially if you are young, as well as additional vaccines if you have complement deficiency, asplenia, or receiving eculizumab or other complement inhibiting drugs. But what we're going to focus on today are the big three: COVID, flu, RSV. So these respiratory viruses are actually really easy. If you are older than 6 months of age, then you should be getting your seasonal COVID and flu vaccines. RSV is a little bit more complex because it's considered for over age 60 and recommended for 75 and up. And we'll come to those patient characteristics that would encourage you to consider getting an RSV vaccine. But again, flu and COVID is easy. Everybody should get them. So this year I was going to start with the flu instead of COVID. This is a snapshot from the California Department of Public Health website that I just downloaded yesterday. This blue line represents where we are in the 2024-2025 flu season. And you can see, just as we saw last year in 2023, 2024 in the green, and in the 2022-2023, that was that first post-COVID year, that we're right on track for a big peak just as we head into our winter holidays. And it tends to start going up in California right around Thanksgiving and then persist through January and February. Now, a lot of people think, oh, the flu, like that doesn't sound that serious, but actually influenza can cause significant morbidity and mortality in kidney transplant recipients, as well as patients with kidney disease. And what does that look like? That looks like a lung infection, a pneumonia that can also be followed by a bacterial pneumonia. And the latest test positivity across California is 9%, which I think is pretty high, considering a lot of people are probably not getting tested. So this is really the one to keep your eye on this week. Now, you might think that the flu shot is not helpful, but this is a study, that shows what are some of the risk factors for having severe influenza. So don't take my word for it. Both end-stage kidney disease as well as increased age were associated with mortality, as was, not surprisingly, immunocompromised status. And you can see if you have bacterial pneumonia after having influenza, your mortality goes up even more. So again, sometimes the flu can be an uncomplicated upper respiratory infection, but sometimes it can cause pneumonia and be life-threatening. And we want to be trying to prevent those preventable illnesses as much as possible. The efficacy of the conventional flu vaccine does vary. anywhere from 15 to 70%. And it is true that having a kidney transplant can negatively impact your ability to respond to the vaccine. Also, being of older age and having some T cell senescence can also impair your ability to respond to vaccine. There is data that getting that high dose vaccine, which is approved for all of you who are 65 years and up, is more effective in terms of converting to being seropositive. And so we do see increased antibody response with the high dose. However, even transplant patients who might have an impaired response to the vaccine can definitely benefit from getting their flu shot. And this is a very well done multi-center study that I like to cite when talking about influenza, showing that influenza vaccination significantly decreased your chance, your odds of either developing a pneumonia, a lung infection, or ICU admission, as was the receipt of early antiviral therapy. While increased risk for ICU admission as well as death in this series were increased age, having 2 or more comorbidities, and being specifically on the immunosuppressive medication, MMF or Cellcept. So the flu shot really works even in transplant patients to decrease risk of severe infection. And it's easy because you can get both vaccines at the same time. If you get some symptoms, some side effects related to COVID or the flu shot, then you can take Tylenol or other medications that your doctor has approved for you to take at the same time and get over any post-vaccine symptoms that you may have together. So I like this. Hey, this goes in with the float theory, right? It takes two vaccines to keep you safe through the winter. So let's talk about COVID, and that's really where I'm going to spend the most of my time just because I get a lot of questions about COVID. This is an old slide, but it's still true that COVID tends to have a very big impact on transplant patients. This was a worldwide study that included over 2,000 patients, 70% of whom were kidney transplant recipients. You can see that the majority of patients in this study were hospitalized, and many had ICU admission and changes in immunosuppression. And 22% did have a negative impact on their allograft function, meaning that their GFR went down after getting COVID. Some of the other comorbidities associated with poor outcome, in addition to transplant, are increased age, end-stage renal disease, and diabetes. So again, just like the flu, although you may have had COVID and you may have had a very mild case of COVID, it can cause severe pneumonia and need for hospitalization and intubation, even now in 2024, especially in people who are unvaccinated or under-vaccinated, and especially in older patients or those with comorbidities. So this is something that it makes a lot of sense to prevent if you can. So here's the latest number from California Department of Health. You can see we're a little behind this year, which is great. However, based on our experience of 2023 and 2022, we should start to see an inflection right about now. So I think the next time that they release this data, we're going to see it starting to go up. And if you look at the wastewater positivity for California and LA County in particular, you can see that that's already starting to increase. So although the percent test positively is only around 2 or 3% right now, this is a perfect time to get your vaccine if you haven't already, because our experience over the past 2 years would suggest that it's going to start increasing in frequency right about now. This is a slide I've used before when we think about COVID, the good news and the bad news, or glass half empty, glass half full. So the good news is that we have widely available vaccines in 2024. The vaccine has been shown to be safe, and it has been shown to be effective in preventing severe disease and death, even in transplant patients and even with patients on dialysis. We do have widely available treatments, and I do have a slide on those this year. And the other good news is that newer SARS-CoV-2 variants, such as Omicron, do seem to be less pathogenic than the ancestral wild-type strain. However, the bad news is that there's still many patients, even patients with kidney disease and other comorbidities, who are unvaccinated or under-vaccinated. And I'm always amazed that when I'm seeing patients who are undergoing evaluation for transplantation, and they've only had the primary series of vaccines back in 2021. They've had 3 years without having a single booster shot. The other glass half empty bullet point is that although we do have treatments, they're actually not that effective, and often you need to be hospitalized to receive treatment. So even though COVID can sometimes just be a nuisance upper respiratory infection, it continues to cause severe disease in some patients, again, including patients with chronic medical conditions. And the other bad news is that although the newer variants appear to be less pathogenic, they appear to be more transmissible. So it's very hard in 2024 to avoid exposure. So you want to be protected for when that exposure inevitably does occur. So I've updated this slide. I don't know if everybody remembers that when we started this whole COVID thing, we were with the wild type ancestral strain. Then we had alpha, beta, gamma, and then delta in 2020 was a big resurgence in infectivity. And since 2021, we've been living in an Omicron world. We're stuck with the Omicron variant. I think it's because it's been so successful and so good at spreading from person to person that we've been parked in Omicron for the past 3 years. However, you can see that WHO and CDC are continuing to identify new variants. So these are subtypes of a subtype. I don't know if you all remember when XBB was in the news last year, and then JN1, followed by KP2. You can see that the two biggest strains that we're still living with right now in the US and in California are KP 3.1.1, and XEC is a new variant that has emerged. And I'm just showing you this not because maybe you're not interested in being a virologist, but this is just an explanation of why it's so important to update your COVID vaccine, because the vaccine that you got in 2021 or even last year in 2023, it's not going to be tuned to the Omicron variant, namely the KPs that are currently circulating now. So it's crucial to get that updated vaccine when it becomes available. The other good news is that we have a lot of choices. So we have two RNA vaccines. They are both updated for this year. So it's the 2024-2025. So when you go to the pharmacy or your doctor's office, this is the only option that's available. So you don't need to specify, I need a booster or I need the latest one. That's all that we have. The Moderna and the Pfizer products that have the somewhat awkward names of Spikevax and Comirnaty are FDA approved. So you can use these vaccines with confidence that they've been on the market for 4 years, that they've gone through the very highest of FDA evaluations, have been given to tens of thousands of people in the US and worldwide. And although every vaccine can have some side effects, and this includes arm pain, fever, fatigue, and malaise, there's no question that the benefit of receiving these updated vaccines far outweighs any potential risks, especially if you have a chronic medical condition such as kidney disease, and or if you are older in age. The other good news is that if for whatever reason you don't want to receive an RNA vaccine, we do have a subunit vaccine that is available under an FDA EUA, that's an emergency action, and that's called Novavax. And that vaccine has been updated for 2024-2025. So that option is out there. The subunit vaccine is the same technology that we use in the flu shot. So it's recombinant protein that's being expressed, not RNA. And although the efficacy is a little bit less than the RNA vaccines, this is a great option if you want a third choice. So again, if you're not sure if you need the COVID vaccine, you just have to ask yourself, when did I last get vaccinated? And if the answer to that question is before September 24, 2024, when these new variant pointing vaccines came out, then yes, you need to get your newest COVID vaccine. If you don't remember, you may be able to see it in your medical portal, or your pharmacist or your PCP may be able to tell you. But if it's been longer than September, you're due. And here is just some data showing that antibody response is impaired in kidney transplant recipients, but this graphic shows that although it is slightly lower in hemodialysis patients compared with healthy controls, nonetheless, it's much superior to transplant recipients and generally is considered to be effective. And if you look at this graph, you can also see why we spend so much time saying if you're going to get your vaccine, and you should get it before your transplant. Because once you've gone and had a transplant, although you can continue to receive most of the vaccines, they're going to be less effective. So the more vaccines you can get when you're not on immunosuppression, the better. Although the antibody response is impaired in kidney transplant recipients, studies that look at the T cell response, which is a different type of immune cell, actually show that the T cell response is pretty similar across the board in healthy controls, dialysis, and kidney transplant patients. And that's probably why studies such as these have shown that although seroconversion may be impaired in transplant recipients, it nonetheless is protective against hospitalization and death. And this is admittedly an old study from wild type or ancestral COVID, but it shows, I think, very clearly in this graphic abstract that if you've had 2 doses of the original COVID vaccine, your mortality was significantly lower than patients who were unvaccinated. And this observation continues to hold true with the newer versions of the COVID vaccine and even with the less pathogenic variants. We're still seeing that receiving vaccines and receiving up-to-date vaccines can decrease your risk for severe infection. So in addition to the vaccine, I wanted to also put in a slide on a relatively new product called Pemivibart. I can't even pronounce it. The trade name is Pemgarda, and this is a monoclonal antibody that is available for prevention of COVID-19. I have to say that the uptake has not been that great, probably because it really doesn't replace vaccination. But in case you've heard of this medication, it is approved only for prevention, not for treatment. And it's indicated for patients with moderate to severe immune compromise who are unlikely to mount an adequate immune response to COVID-19 vaccine. So that might mean kidney transplant recipients, especially of older age. Unless you're in a special circumstance, I would think that most people with chronic kidney disease, even if they're on dialysis, would not need this Pemgarda extra level of protection. But I think it's useful to know that it is out there if needed. And I also wanted to briefly talk about what if you test positive. So currently, we're often just recommending supportive care at home if you have mild symptoms. However, if you have more severe symptoms, including shortness of breath, or if your oxygen level is low, we've got 3 treatments in 2024. We've got Paxlovid, we've got Molnupiravir or Lagevrio, and we've got Remdesivir, and the trade name is Veklury. I did put in yellow here that you need to be very careful with Paxlovid because it has multiple drug-drug interactions. It interacts with oral anticoagulation medications, so that like Eliquis, that can be very hazardous. And it also interacts with tacrolimus or cyclosporin. So if a physician offers you a Paxlovid prescription, make sure they know all the medications you're taking, and maybe have them check once or twice to make sure there's no drug-drug interactions. Molnupiravir is an attractive option because it's oral, but it does appear to be less effective than Paxlovid. And we do have Remdesivir, but as I mentioned before, it does usually require hospitalization or you need to go to an infusion center because it is IV only. And although these treatments may provide some benefit, they're often ineffective or only slightly effective in patients with severe disease, patients with older age, or patient with multiple comorbidities. So again, this is a common question that I've gotten from patients as well as physicians who will say, oh, why do I need to get vaccinated? Because if I get sick, you can just treat me. And the answer is yes, we do have antivirals, but because they're not very effective, you really don't want to be relying on treatment here. Prevention is better. And although we can treat your COVID infection, just like with the influenza, you can get a secondary bacterial or even a fungal infection that could be quite serious. And then we always have to also worry about long COVID. So better to prevent. All right, I'm going to shift gears now. I'm just checking on my time here and talk about RSV, or respiratory syncytial virus. You may never have heard of this virus, but you most likely have had it. It's actually the most common respiratory viral infection in transplant recipients, and it is also a common cause of severe disease in the very young, shown by this cute little graphic, and the very old. So normally you'd experience it just like the common cold. However, for people in these high-risk groups, you can develop a severe pneumonia that can be fatal. So here's my California Department of Health graph for RSV. So you can see all three of these tripledemic viruses. They have all this information right on their website. You can check it out. You can see that right now we're on the beginning of an upswing. We're right about at 5% right now. Right after COVID, we had this delayed season in 2021 that was quite deleterious and had a lot of significant morbidity and mortality in older and younger patients. You can see in 2022, it came a bit earlier and looks like we're really on track for kind of a late peak this year, but it's up and it's going to continue to rise. So because older adults are at increased risk, as are pregnant women, although that's outside the scope of my expertise, let's talk about who should be getting the RSV vaccine. Oh, I'm sorry, and one more slide showing you how bad RSV can get. This is a study from Korea that I just really like this graphic. So the bar graph shows how frequent is RSV versus influenza. And in this particular cohort, you can see that influenza was actually more common than RSV. And this was older patients, not necessarily transplant patients. However, what they found was that although they had more cases of influenza, the hazard ratio, or the risk of death in RSV compared with influenza, was much higher. It was 2.3. And that's probably in large part because we don't have a treatment for RSV. So with influenza, you can get Tamiflu. With RSV, we don't have an effective antiviral medication. And folks were most likely to die from RSV, again, with increased age, with chronic lung disease, and if they experienced pneumonia. All right, so this is just one of the vaccines that's currently on the market, but all of the data is very similar, so I'm just going to show you one. So this was a very nicely done phase 3 randomized placebo-controlled trial. You can see that they enrolled over 25,000 participants worldwide across 17 countries, and they were assigned 1-to-1 to receive either a single dose of the RSV vaccine or placebo. And you can see in this Kaplan-Meier curve that the incidence of RSV was significantly higher in the blue in folks who got the placebo compared with folks who got the RSV vaccine. But when they looked at safety, that was actually quite excellent. Although 70% of recipients who received the actual vaccine had a adverse reaction, those reactions were extremely mild and were generally pain at the injection site, redness at the injection site, fatigue, and fever. Very few significant adverse reactions were seen. Again, they're mostly mild to moderate. And this led to CDC and ACIP and FDA recommending and approving. I just showed you data for the GSK product, Arexvy, but all three of these RSV products are now available. So it's really an abundance of riches. Maybe it's bad news for the pharmaceutical companies because they're in a pool competing with two other vendors, but it's great news for patients. If you go to your local pharmacy and ask for an RSV vaccine, I'm very comfortable recommending all three of these. So I showed you the data for Arexvy. That's the GSK product that has an adjuvant that's similar to Shingrix. Pfizer also has a product called Abrysvo, and this is the one that's also indicated for pregnant patients. And we now also have an RNA vaccine from Moderna, and they all have the same indication. So it's very easy. So whichever of these three flavors you get, think of it like chocolate, vanilla, or strawberry. They're all excellent. The recommendation is that if you're 75 years of age or older, you should get one of these RSV vaccines. And if you're in that kind of gray zone between 60 and 74, the recommendation is to consider getting the vaccine if you have a risk factor. The risk factors do include chronic kidney disease, dialysis dependence, heart, lung, or liver disease, weakened immune system, so transplant patients, diabetes, obesity, or frailty. At this point in time, we're just recommending that you get a single dose of RSV, and there is some data for patients who are vaccinated, like in year one, that in the second year that they did have some persistent protection. It may be that at some point in the future, we're going to recommend that folks get a second dose of these vaccines. But at this point in time, the recommendation is just to get one, and you should be in good shape for 1, 2, or possibly 3 years. So older adults should be getting all three: flu, RSV, and COVID-19. Oh, look, and I have a typo here. Unconsider. So just to put these three in context again, everybody who has a comorbidity should be getting the MMR, Tdap, Shingrix, Prevnar, hepatitis A and B, human papillomavirus if you're young, especially if you're sexually active, these Hib and meningococcus vaccines if you have complement deficiency, and everybody should be getting COVID, flu, and consider RSV. Just wanted to show you the source for these recommendations, and that is this published schedule from CDC ACIP. And if you are a transplant candidate or a recipient, you're going to want to look in this column here, immunocompromised. If you have end-stage renal disease and for whatever reason you're not a transplant candidate, then you'd be looking here under kidney failure. So that's where all this data is coming from. Great resource. But what about masks? This is an old slide, but it's just important to highlight that although vaccination is a crucial part of protection, wearing a mask during high-risk situations continues to be a very good idea. For instance, when you go to the doctor's office, especially if you're sitting in that waiting room, you've got no idea who might be there. Maybe they're there because they have a respiratory virus infection. So it's a good idea, in my opinion, in the healthcare setting to continue to wear a surgical mask. And you may want to consider wearing a KN95 or KF94 if you prefer the Korean models. If you're in an especially high-risk situation, such as you're indoors, maybe on public transportation or some other situation where you have to be indoors for several hours with people whose vaccination status you do not know. I recently traveled to Maryland for the ID Week Program Planning Committee, and I did wear a KN95 on the plane, and I was glad I did because I could hear a lot of coughing in the rows in front and behind. Okay, so I am going to get to the questions in the chat, but I did want to share some questions that I received quite a bit. One question is, I already got 4 COVID vaccines. Do I really need another? And as you know now, the answer is yes. Unless you got your COVID vaccine after September 24th, you need to get another vaccine. Another question I get a lot is, I've never gotten the flu. Why do I need to get the vaccine? And great that you've been so lucky. However, it's really a good idea to get the vaccine because you never know whether this season might be the time where you get a severe infection that could even be life-threatening. So really better to be protected. A lot of patients also say to me, oh, every time I get the flu shot, I get the flu. Interestingly, when people tell you this, the time course between when they get their flu shot and when they say they're getting the flu really varies. Some people say, I got the flu that day versus the next day versus a week later. And so people often have this perception because during the months when we're encouraging people to get the flu shot, October, November, December, there's a lot of respiratory viruses that are circulating. So it's very easy to jump to the conclusion that the flu shot gave you the virus, but that is actually not biologically possible because of the way the vaccines are designed in terms of subunit or a piece of RNA. Also, I think sometimes people confuse feeling unwell because they're having a vaccine reaction because their immune system is working. They think, oh, I'm sick. But it might just be that your immune system is responding to the vaccine, which is a good thing. Okay, my next question. I'm a transplant patient or I'm on dialysis, are these vaccines safe for me? And the answer is yes. And we've got great data over 4 years to support that. And in fact, if you're a transplant patient or on dialysis, you're at increased risk. So it's even more important to get the vaccines. They are safe for you. And finally, often get the question, I never go out. Why do I need the vaccine? And I can tell you, I've talked to so many patients in the emergency room who are there and they're feeling sick and feeling terrible with COVID or the flu, and they've never left the house. So as long as there's other human beings coming in and out, there's a chance that you're going to be exposed and someone is going to get you sick. So you should still get the vaccine. So in summary, this is my last slide, and then I'm going to look at the questions. Get that newest COVID vaccine if you haven't already. Get that seasonal flu shot if you haven't already. And if you're over 65, get the high dose. Consider the RSV vaccine if you're over 60. And if you're over 75, you should definitely get it at least once. Make sure your friends and families get vaccinated because they're the beautiful people who are going to get you sick. And in addition to vaccines, hand hygiene is still important. Using gel, being aware of contaminated surfaces, wearing a mask in high-risk situations, and staying away from sick people. And someone had asked by email, do I still need to be, sort of living in a bubble in 2024? I think the answer is no, at least for most patients, with maybe the exception of someone who's just had a stem cell transplant. I think that the current era where we are, it's important to be up to date on your vaccines. But I think that we can consider leaving the house and taking part in activities, possibly with or without a mask. And the individual risk that you're willing to take really has to depend on how important that event is to you. So, in other words, if someone invites you to go to a concert and you really don't want to go, hey, say no thanks. I don't want to get sick. If you're going to be attending, say, the wedding of a family member, you should probably attend, maybe find out the details about the crowd size, the indoor, outdoor, et cetera, but you should definitely go to that important event. And you can work with your nephrologist, PCP, or ID doctor to think about how to make that event safer for you. But I think the era when we're asking people to avoid all contact with the public is thankfully over. All right, so that was, as promised, my last slide. I don't know, Dr. Rastogi, if you had anything to say, or if I
That,
should just jump in, or if you wanted to read some of the questions.
I mean, the only thing that I would like to say or just reinforce
Mhm.
what you said is prevention, prevention, prevention.
Yes,
And but still live your life. There's a question
right.
that we got in the email about bubble. Can I read that question? Because I
Yeah,
think
yeah, please
that,
do, because I do get that question quite a bit, and it makes me sad, honestly, because we need to come up with a balance.
yes, balance and live your life because that leads to mental health issues.
Absolutely.
So I'll just read the question straight. I'm a kidney transplant patient in my early 60s, 14 years out, was transplant at UCLA. I keep up with my vaccinations, including my COVID vaccine over the last 5 years. I haven't gotten COVID yet. For what it's worth, my measured antibody levels have always been very high. My family has led a very cautious
Mm-hmm.
and a pretty isolated existence for the last 5 years. Masks in any indoor space, no airplane travel, no
Mm-hmm.
indoor restaurants. It has been stressing to say the least. I'm looking for some guidance on how much we can relax this regimen. Can my daughter stop wearing a mask at school? I don't know
Mm-hmm.
how old the daughter is, but
Mm-hmm.
is the risk of air travel with masks acceptable? Indoor restaurants, parties, will
Mm-hmm.
we ever be able to go back to quote
Mm-hmm.
unquote a normal life?
Right, right.
And if I
So,
ever were to get COVID, what is the likelihood of developing a serious, potentially life-threatening
mm-hmm.
response?
Mm-hmm. Right. So I think the answer to those questions is yes, it's time for you to get back into a more normal life. I don't think your daughter needs to wear a mask at school anymore unless she's attending a very high risk, specific event such as an indoor concert. But I think that wearing a mask every day at school is probably very difficult. I think air travel is acceptable. I would recommend wearing an N95 or equivalent mask. And in terms of restaurants, again, I think you just have to pick and choose. Height of the winter season, going to a crowded restaurant or bar with, say, a big group, boy, you're probably going to get sick. That might not be a great choice for you. But maybe you've got a few good friends. You want to see them in a restaurant that has good ventilation, maybe during the day, or maybe you delay it till February or March when the numbers are coming down. I think you can definitely go out and get that restaurant meal, but I still want people to use common sense and not feel that we can just drop all precautions. We kind of need to make an informed decision about every potential risk situation. And at the end of the day, like you said, Dr. Rastogi, we have to live our life, and the mental health is important. We love when people get transplants and get their life back in terms of not having frequent dialysis. So it's important that you're having good quality of life, but you just have to balance that against extremely high risk situations.
And once again, what you said is, if you go out early, right? So it's not
Right,
crowded.
exactly.
Avoid
Yeah.
places. So finding a balance, and then we'll leave it up to your judgment because at the end. But also, I think the other thing that I want to point out, Dr. Schaenman, is, and I know Dr. Sarkar is on here too, is that this at UCLA we have a team, right? The COVID team and response,
Mhm.
and you put them in, and they'll help you what medications and stuff. So whatever healthcare system, and I know there are a lot of people from outside California. We have somebody from
Mhm.
Denver,
Hmm.
from Georgia,
Wow.
finding out who that person is or team is, right, in advance. So if the things do develop, they can triage it quickly and provide you the right guidance because your primary care physician or even your subspecialty might not be up to date with everything that's going on, but that team might be. So we have
Mhm.
Sarkar.
Mhm.
Sarkar, do you want to say anything or before we get to
I just wanted to congratulate Dr. Schaenman again for a fantastic talk. And Dr. Schaenman, had some questions that come up in clinic, especially with transplant patients. And one of them is like going forward. I mean, we have been coming out of the pandemic. We have successfully kind of come with some vaccines that are preventative. But how long are we going to do this? And is this my life every 6 months? Is the question that I
Mhm.
get.
Yeah, yeah. I think no one knows for sure, honestly. I think most experts in the field think that we're going to probably get into an annual vaccination situation similar to the flu shot. So that's what I would expect. Sadly, I think COVID is here to stay. It's been such a successful pathogen in human beings. I think it's now become endemic and it is going to be part of our lives, unfortunately. However, the good news is that we can continue to design vaccines to fight it. You saw the COVID variants. If there happened to be a sudden shift in variant and we felt that our current vaccines were not effective, maybe we'd have a special event, like a pop-up sale where we would do a new COVID vaccine. But barring that, if we continue to just see the slow drift of the Omicron variants, what I would predict is that it's going to become an annual vaccine. And so every October, we'll be saying, get your flu shot, get your COVID shot. So, yes, sorry, it is probably going to be a forever thing, but I don't think we're going to be doing this craziness of the past where we were giving multiple vaccines.
yeah.
Um, Thank you again. The next thing that I captured from the chat was like a lot of people had questions about timing these vaccines. Can they
Yes,
spread them out?
yes. Yes, that's a great question. So the good news is that if you had a natural COVID infection, and I'm sorry you had one, and hopefully it wasn't too severe, you're in a perfect situation to have a dynamite response from vaccine. Because we have data from our laboratory, meaning Dr. Elaine Reed at the Immunogenetics Center and others, showing that if you get a sandwich effect, vaccine, natural infection, and then vaccine, your antibody and T cell responses will be excellent. We usually recommend that people wait at least 1 month after a natural infection, or certainly until they're feeling reasonably well. So for this particular question, if you had COVID in August, it's definitely time for you to get your COVID vaccination and take advantage of that sandwich effect before your natural antibodies start to wane again.
The next one I have, Dr. Schaenman, is it true for RSV too? that if I had an RSV infection, do I need to still get vaccinated?
Yes, yes, definitely. You know, with RSV, there's also a lot of subtypes. There's RSV-A and there's RSV-B. All three of the vaccines include antigens for both A and B. So you can, and people do get RSV year after year. And it seems like RSV, just like for COVID, that there's really no substitute for vaccination. In other words, these viruses are very smart. And so, yeah, we've all had the common cold a million times, right?
Yeah.
Because there's so much mutations and variation from year to year, the viruses come back and get us again. And also, our natural antibodies tend to wane after 4 months or so. So the vaccines seem to be able to do something that's different from natural infection because of the way the vaccines are engineered and the adjuvants that are included with them that provide a very good stimulation to your immune system. Instead of just having a few months of protection, you can have years of protection. And so specifically with RSV, again, as I mentioned, there's data showing that 2 or 3 years after the RSV vaccine, you're still seeing protection. I think someone did ask in the chat if RSV is an annual vaccine, and the answer is not at this time. Again, to use my vaccine crystal ball, I'm guessing that they're going to put on it like maybe every 3 or 5 years, kind of like it used to be with Pneumovax. And so maybe that's one that you'll do periodically, but not on an annual basis. Also, the other thing to watch for the future is that at ID Week this past year, vaccine companies are looking to combine vaccines together, which I think is great and is going to be very convenient. If you think about it, MMR, a trusted vaccine from childhood, is measles, mumps, and rubella, right? And Tdap, that's, the tetanus vaccine. And then you also get pertussis in there. So I think that in the future, maybe as soon as 2025 respiratory virus season, you're going to be offered a combination flu and COVID vaccine from your pharmacy. And I think that's going to really help people be compliant with recommendations and stay up to date without too many jabs.
Great. I think right there was another question about, and this comes up a lot in clinics about do getting all of them together dampen their immunogenic like effects, the immunogenicity.
Right. So as far as I know, there's not data for doing the triple axle. I'm not aware that any manufacturer has tested giving RSV, COVID, and flu all together. So it's probably okay, but I would not recommend that just because we just don't know. So I would say you pick your top two, and in my case, I typically go with the COVID and flu because those are generally the most common infections. Make sure you get those two out of your way, and then you can do the RSV at a later time. I think someone asked in the chat about spacing. I think 2 weeks is fine to give your immune system a break, and so that you can get over whatever, local reactions you might have had from the initial vaccine. However, there is also data that you can do the influenza with RSV. So that's also an acceptable combination. And I would say that most pharmacists are pretty aware of what can be combined safely and what should not be combined.
Yeah, great. I had one personal question, and it comes up about the monoclonal antibodies in COVID, the Pemgarda and the Evishields.
Yeah.
So, I mean, do we still recommend them? I think the Evishield kind of phased out because of the variants changing. And
that's right. Yeah, Evishield, is no longer available.
Yep. And then do we recommend the Pemgarda for really immunocompromised patients, and how often they should be getting it?
Yeah. So right now the Pemgarda is just approved as a single dose. I do think it should be considered for people who are very immunocompromised. Luckily, that doesn't include most of our kidney transplant patients, although I could think of a scenario. Let's say you had someone who came into transplant, got their kidney, and then had rejection and had to get ATG, and they hadn't gotten their COVID shot that year. We can safely give them a COVID vaccine, but they might not respond to it because of the immunosuppression.
Right.
I think those patients maybe should also get Pemgarda, or if we had a kidney transplant patient who is really quite elderly. However, I think the main targets for PEMGARDA are going to be more BMT and lung transplant. The folks really sit at the top in terms of immunosuppression and risk. So for most kidney transplant and certainly for CKD patients, I don't know that PEMGARDA is really going to be necessary unless there was some reason why they couldn't get the COVID vaccine, which again, you could think of some examples, but in general, I don't think we're going to see much PEMGARDA in our patients.
Right.
Yeah.
Okay, that was me, Dr. Rastogi. It's
Yeah,
all you.
okay. I see someone asked about Prevnar, and that's a
Yes.
great question. Mid 40s, GFR 89. I would say it's not essential, but I mean, if you're ever going to be considered as a transplant candidate or recipient, you just want to make sure you get that Prevnar uh, before you get the immunosuppression. And because in adults we often see pneumococcal infection after respiratory viruses, I would make sure that you're up to date with your COVID and your influenza vaccines.
And I think you have answered all of the questions.
I do see a question in the Q&A that I think I accidentally flagged as answered, and that was the question about the chances of contracting COVID.
I can open that up, Shannon.
Okay,
So
okay.
I'm going to read it. It is,
Okay, please.
I'm wondering if there are statistics out there regarding people who are COVID-19 vaccinated, have also worn an N95 mask. What percentage of people are still contracting COVID-19 after wearing an N95 mask and vaccinated?
And so, nothing is 100% in life or certainly in medicine. So I would say, first of all, I don't have a number to give you. I have seen people who tell me at least that they always wear an N95 and are up to date on vaccines. I have seen people like that get sick often from household contacts. And they're often more immunocompromised, namely lung transplant recipients or older age. So I guess all I can say in response to that question is every layer of protection is going to decrease your chances of getting symptomatic or severe COVID-19, right? So if you're completely unvaccinated and you never mask, then you're really walking around naked. You're extremely at high risk. If you've had the latest booster and you're wearing a high quality mask, your chances of getting COVID is going to be significantly lower. But we can never get quite down to zero. And again, I would say household contacts is huge. Again, thinking about when I'm seeing patients in the emergency room and I'll ask them, where do you think that you got COVID from? They'll often turn and point at their spouse. And that's just the way it is when you're in a house, you can't mask 24/7. So that's why it's so crucial to make sure that your household contacts are vaccinated. And I think that's why we healthcare providers make sure that we always get our annual vaccines. That's why I always wear a mask when I see patients, because I want to be sure that I'm not that close contact who gets my transplant patient or transplant candidate sick. Okay, so this person is also asking if you got the COVID vaccine in September, do you have to get it again? So right now the recommendation is no. I mean, I think there's nothing to prevent people from getting multiple COVID vaccines, and I still have some lung transplant patients out there who are doing that. But I don't think we really have high quality data that doubling down on the same vaccine, like the same year, the same variant target, is that useful. The other good news is that compared to when we were just starting out with this darn thing back in 2020, 2021, most of us were naive to COVID. So it took a lot to kind of jumpstart the machine and trigger that antigen specific T cell and antibody response in people who were naive, especially when they were taking immunosuppression, especially CellCept. But this at this point in the game, I don't think anybody is completely COVID naive. I think almost all of us have been exposed to wild type COVID, even if we weren't really aware of it. So that's bad news in terms of long COVID risk, but that's good news in terms of the vaccine. So that means that even if you're a kidney transplant patient, you've probably had an infection in your past. Hopefully you've been vaccinated in the past. that means you're in that good sandwich situation, vaccine, natural infection. And when you get even one time of the newest COVID booster, you should be protected for several months, hopefully long enough to get us out of this dangerous winter respiratory virus period.
Great.
Yeah.
This is awesome, Dr. Schaenman. I know you have a
Yes, I do.
um,
But I want to say one more thing, though, because I have another very nice, thoughtful question in the chat that I really want to address, and that is, are we concerned with the new administration? I think the honest answer from everybody in the field of infectious diseases is that, yes, we are concerned. However, anyone who is participating in this webinar, either live or is watching the recording, is someone who's concerned about healthcare and is getting themselves educated. And I have faith that with the efforts of primary care providers and specialists such as nephrologists and infectious disease providers and public health, that we're going to continue to have vaccine availability, but it may just be a little bit harder to get high quality information. So I would say this is an important time, like you're saying before, Dr. Rastogi, to know who's your healthcare team, have that connection, identify who's your go-to person, and work with that person to stay up to date with vaccination as we go forward. At least here in California, I think that we're going to have ongoing involvement and engagement from the California Department of Public Health. However, as you mentioned, there's people on the call who are outside of California, maybe in different situations. So continue to look to CDC for high quality information and look to whoever is your most trusted provider to guide you through your need for vaccines in the future.
and Dr. Schaenman, I just want to put it out there. Hopefully this is a quiet, winter and season. But if there are more challenges, I'm sure you'll be coming back and speaking to them and guiding them. So hopefully we don't need you this season again. As you do our annual. But if you do, I'm sure you'll be here answering questions and resources. So I want to thank you. I just want to second what Dr. Sarkar said. You're amazing, Dr. Schaenman. Thank you very, very much for spending your time, during this season to help our patients. And I'll see you at least at some point at the Rose Parade. The building. Yep.
Absolutely. Okay. Thank you for the opportunity to speak to this wonderful group, and thanks for all the thoughtful questions, everybody.
Thank you, Dr. Schaenman. Thank you. We really appreciate you. Thank you.